So we're going to go quickly through how to approach on imaging of the brain. Then the three of us will actually go through a little bit of radiology jeopardy. And if you have any questions, and I think there might be some time for questions, that is if you guys want to hang out, or there may just be a stampede out of here directly after I see like, yes. There's a lot of information today. So I know you guys are probably pretty saturated. This one I think is also a very important topic. Stay in the box. Okay, I'm in the box. Trying. Okay, so again, disclosure, I work on an app for ultrasound, and my goals today are to review the natural anatomy of the brain. We're going to go through an approach to imaging of the brain in trauma and also in non-trauma states using both CT imaging and also MRI imaging. So we'll go through an approach, and by the end of today, you guys are going to be board-certified neuroradiologists. How's that? And you get the Aston Martin drives up right out in front of the Planet Hollywood right after this lecture, and you get to pick the color. How's that? All right. So onwards. Another picture from Netter. This has to do more with the cracking of your skull when you smash your head in a car during a car accident. You have that very strong frontal bone. Don't forget the maxilla. This is really more of a lecture on facial trauma, but you can see we have the maxilla down lower. And if we spin the head around, we can actually see the frontal, and right in back of it, we can see the parietal. And below it, we can actually see the temporal region, which is pretty well protected, but some fractures will actually go down from the parietal all the way down through the temporal. The occipital bone, commonly fractured by people who fall off bar stools backwards, right, in Vegas, and go on backwards onto the back of their head. The sphenoid, the yellow bone in there, is very hard to get to, so I dare you to try to fracture your sphenoid. That would be, you'd have to really try hard to do that one. But remember the different bones when you're kind of looking for a skull fracture and describing that to your neurosurgeon. Remember that the skull has some natural suture lines. These are not fractures. They're paired, they're symmetrical, and they should be there in every patient. So if we look in the front, we can see the coronoid sutures on the front end, and towards the back, we see the lambdoid sutures. So don't make the mistake that those are actually fracture lines. You'll see that they're perfectly symmetrical and paired. We also have the sagittal suture line that goes right down the middle. Okay, so those are the normal suture lines. If we look and see what they look like on CAT scan, here's the coronal sutures. Again, symmetrical, bilateral, not fractures, normal. Okay. If we look in the back, we see lambdoid, and we can see again normal, symmetrical, paired. And if we go all the way down, we can actually look, if we're interested in looking for things like patient comes in with hemotympanum and we're worried about basilar skull fracture, we may want to do cuts down through the temporal bones, down by the ear, and actually the ENT doctors will sometimes like very, very fine cuts. We're using basically 1 to 5 millimeter cuts on CAT scan imaging of the head and the brain. They'll sometimes go down to 2 millimeter cuts for looking very, very closely to see if the patient has a temporal bone fracture that they may have to go in and repair if the patient has, for example, a battle sign or hemotympanum or a leak. Here we can see this is a patient who fell over backwards after too many drinks playing up on the craps table. And you can see there, fell over backward. We have, this is not a suture. We notice that it's asymmetrical. We also see there's some suture material outside. One of the residents has already gone and sewn this patient up. And we have a depressed occipital skull fracture that's present here. How about this one? Okay, I don't think any of us would miss this. This is a patient who was not wearing their seatbelt, high-speed motor vehicle accident, thrown directly into the dash, boom, and we can see there's a depressed skull fracture. Now, where there's smoke, there's fire, and if I flip this over to the brain windows, you guys would all be, it would not look good, okay, and that will be coming down the pike. The first thing is just looking for the skull fracture and making sure that you do look in a methodical pattern. I like to really look first through the skull windows. Here's another one. This is a patient who was assaulted, and we can see here there's a depressed skull fracture. Notice that it's involving the parietal and goes all the way down, so it's temporal and parietal. And the problem with this one is, do you guys see that it's actually depressed greater than 1 bone table width down? And that's a problem for the neurosurgeon, because if you do have a depressed skull fracture and it's greater than 1 bone table width down, many times they'll try to elevate that up. And in fact, this patient did go to the operating room and got surgery. Okay, you don't want to have that thing kind of poking around in your brain as you're going around your business. Okay. Here I thought this was an interesting one. This is a patient who came in, got hit to the head, assaulted. And if you look on this image, I think I see a skull fracture. I'm pretty sure there's a skull fracture. But remember doing this in a methodological way. I want to go ahead and put it on the bone windows first of all, and now you can really, really see them. Okay, do you guys see the difference there? So look first to see if there's a depressed skull fracture. That's going to be very important for your neurosurgeon. Try to describe it. I like the way Bob was talking about, in terms of the ring and the different fingers. So if you can describe it in terms of the region, this is a depressed frontal or depressed parietal temporal, you'll sound really smart to the neurosurgeon. Bonus points for that. Okay, the brain underlying. So you have that hard cranium on the outside, the soft shell of the brain underneath, the frontal, your motor cortex, your parietal, which is going to be your sensory, and your temporal, occipital, your ability to see, and temporal lobe, who you are, right? Basically makes you who you are. So we're not really going to go through stroke imaging in this lecture, but a general idea in terms of where the lobes of the brain are. How we were created by our Creator is that we have a great hydraulic system within our brain that cushions the shock that our brain takes as our brain may hit up against a wall or hit against a car or fall 20 feet off of a balcony. And we have a system of shock absorbers known as the ventricles. So the first are the lateral ventricles. Notice that we have very, very broad lateral ventricles up high. We have the exodus of the CSF is through the foramen of Monroe from the lateral ventricles down into the third ventricle. And we see the third ventricle right in the midline. That's going to be right adjacent to the thalamus, and we'll see that on some of the cuts. And then we see how the CSF gets out of the third ventricle through this very long aqueduct of Sylvius all the way down to the fourth ventricle. Now that's the problem in the design. If I was going to design your brain and I was going to design your ventricles, I would not make that little aqueduct of Sylvius so small. And the reason is that many times that's where blocks occur, and patients can get something called a communicating hydrocephalus, where little masses or infections can push on that, right in between the third and fourth. So everything gets inflated, from above the third ventricle, but the fourth ventricle is small. Okay, so that's one way of distinguishing. That would be a non-communicating. A communicating one is where they're all communicating together, where it's basically all the ventricles are large. And just so you believe me, to the right, I have Exhibit A, which is showing blood from a subarachnoid hemorrhage within the ventricles. And you can actually see the blood starting in the top and the continuation of the process below. Notice the blood is going down the aqueduct of Sylvius down to the fourth ventricle. And what do we see about the size of the ventricles here? Do you guys see a difference in the size between the top and the lower? Look how much bigger the lateral ventricle is now. So we can see that when blood gets into the aqueduct of Sylvius, it basically causes an obstruction. And so that will give us hydrocephalus, and many times a neurosurgeon will have to go in and do a bolt. Okay, so they'll go and put a bolt to drain your CSF. Okay, so when you see blood within the ventricles, always bad. Cranial anatomy. Okay, so this one, this is the one I like to joke, there'll be a small examination afterwards. I can usually get my residents every time on this. But I think the takeaway point is that we have a global understanding of the brain. Remember, we have the cerebral hemispheres, the lateral ventricles, and as we move down, we start to see the midbrain. I put there the QP, which is the quadrigeminal plate of the midbrain, and that's a very important structure. There's a cistern right in back of there, and then it goes pons and midbrain, okay, pons and medulla as we go down, okay. So just remember that as we're kind of looking through this, we can also see that there's spaces where the CSF can travel outside of the ventricles. And remember that the CSF will go through the ventricles and then drain outside the ventricles into the cisterns. And I'm just going to show you a good way of remembering these cisterns. And if we slice all the way down from A, B, C down to D, going downwards, we have a nice way of remembering the cisterns, okay? Now, I don't expect you guys are going to remember these later, but we'll give it a shot here, okay? So A is right above the cerebellum, so we're going to call that the superior cerebellar cistern. B is the quadrigeminal plate cistern, and that's going to be right up against the medulla. The midbrain. As we go further in front of the midbrain, we actually see C, which is the interpeduncular cistern, and then up in front of that we see D, which is the suprasellar cistern. Down below, right around the spinal cord, we see a very large cistern known as the cisterna magna. Now, why are these important, and do I have to remember them all? I think the most important thing here is that you understand that these need to be open. This is a normal size of the cisterns. When we start to see a loss of the volume of the cisterns, especially in the setting of a mass or a bleed, that means that things are starting to shift downwards, okay? So when the basilar cisterns, which effectively these 4 cisterns are, start to become effaced, that is a very bad sign, that we're starting to get uncal herniation, and the brain is starting to shift downwards onto the spinal cord and may stop breathing imminently, so not a good thing. So let's go through on an approach on reading a head CT. We'll start with an axial view. Starting at the very top, we can see here's the falx, and we can see we're up very, very high, and we can see that both of the sides of the brain to the sides of the falx look about normal. The gyri look about equivalent bilateral or bilaterally. As we move further down, we see a little bit more of the brain, and now we start to see the centrum ovale, which is the gray-white junction of the brain. And as we come even further down, now we're starting to see the lateral ventricles, the anterior horn, as well as the posterior horn. Okay, so you should see that. And take a look at a lot of brains so you get a sense of what is a normal size in terms of the lateral ventricles. This would be a pretty normal size. Right adjacent to the lateral ventricles are going to be the caudate and the thalamus. And these are really critical areas because in many of our patients with hypertension who might come in with a serious headache, very high blood pressure, and have some neurological findings, this is the first place you're going to look for a bleed. And this is a classic place for a hypertensive bleed. So the caudate and the thalamus. And this is a patient who has a little bit more of a degeneration, more atrophy. The ventricles and the cisterns here are more prominent. We can see that the third ventricle is wider. We can also see the superior cerebellar cistern right in back of the third ventricle. Notice how much larger it is than the patient who had a lot of brain. As we move further down, we see the third ventricle, and now we're seeing that quadrigeminal plate cistern, which I call the smiley face, and that's going to be right posterior to the third ventricle. In a patient with more atrophy, now we start to see the lateral ventricles, which I characterize as the eyes, the nose, which is the third ventricle, and the smiling face of the quadrigeminal cistern. Okay, so you can see a little bit more atrophy here. As patients get even more atrophy, what's kind of interesting is that the brain grows a mustache. And what happens is that you get the lateral ventricles, the temporal horns, come right on top of that quadrigeminal plate, making the mustache on top of the patient's smiley face. I don't think this patient is smiling, actually. It looks kind of angry at me at this point. But you can see how with atrophy, everything becomes much more prominent. Okay. Further down, we can see the interpeduncular cistern right in front of the midbrain. As we go further down, we can see with a little bit more atrophy that suprasellar cistern and the interpeduncular cistern become much more prominent. And we can see the midbrain right there, right below the lateral ventricle. In this case, we see that the suprasellar cistern is very, very prominent, as is the fourth ventricle. So in this patient, I would say this is just global hydrocephalus or atrophy, because it looks like everything is dilated about equivalent. So we have, basically now we have a very good look at that fourth ventricle moving down through the cerebellum, okay? And as we go further down, the fourth ventricle is really your landmark for examining the cerebellum, because we know on CAT scan is not really the best modality for seeing your cerebellum. Around the cerebellum, there's a lot of bony, there's a lot of hard bones that tend to refract the CT beams, and so it makes it very hard to image that region. So this is an area, if you're really pressing, really saying, I think there might be something within the cerebellum, you might need to go to a CAT scan. But one of the tip-offs here is that fourth ventricle right in the middle, okay? Because if there's a mass, something could be pushing it over to the side. So make it a point to go, I like to start at the top in the axial cuts and work my way down in a methodical way on every patient, okay? I don't have time to look at all the reformats, but I can at least look at the axial and a couple of the coronal cuts. So this is just going further down. We see the fourth ventricle and the cerebellum. And here we have the pons medullary junction and the fourth ventricle. And what I really like now is now with this new computer reformatting, we can actually spin the brain around and reformat it into multiple different orientations. I find the coronal view to be one of the most important views to take a look at in a patient, especially with trauma. Many times it was very hard to see subdurals that were layering along the vertex of the brain in the past on the axial cuts. Using the coronal view, we can actually see it so much easier, and I'll show you some examples coming up. Notice we see the falx. That's a normal falx, by the way. Okay, I want you to take a look at a lot of falxes as well. The falx will have a little triangle, which can be a little bit thickened and can be calcified. That's not a subdural. We'll show some examples of what a subdural would look like. Here's a patient with a lot more ventriculomegaly. I call it the crying eyes, and we can see this patient is not happy. The lateral ventricle is very large, and we can see a very large fourth ventricle crying out for help. So very severe ventriculomegaly in this patient. Here's an interesting case. This patient kept coming in, was getting shunts, they were failing, kept coming in and having more neurological symptoms. Here, if we look at this is not so much atrophy as it is hydrocephalus. And we can see that there's a lot of brain here, but notice how large the lateral ventricles are in relation to the amount of brain, okay? And if we look even further down, look at the size of the fourth ventricle. My God, it's like an ocean. Okay, so it's huge, gigantic. And we can see the shunts are in there, but the shunts apparently are not working. So this poor patient had to have another revision of the shunt again to get this working. Okay, so that is a communicating hydrocephalus all the way down to the fourth ventricle. Remember we said that if the fourth ventricle is involved, that's communicating. If the block is between the third and the fourth, that's a non-communicating. We've seen this before, midbrain pons medulla, cerebellum, and the basilar cisterns. And I will not quiz you again on this one, but notice that they're all open, okay, that we actually have fluid surrounds the lower parts of the brain. That's normal, okay, so no evidence of high pressure on this case. So let's start taking a look at some cases of clear pathology. This is a patient who comes into the emergency department with a blood pressure 220 over 140, severe headache, and the patient is very ataxic and has got some nice sagmus. I think the question that comes up to me a lot from my residents is, do I need to scan every patient who comes into the emergency department with a headache? And I think we would be doing a lot of CAT scanning if that's what we were doing. However, this patient had frank neurological deficits, and when I tried to get the patient up to walk, the patient was very unsteady, okay? So tip off that there could be something going on here. And so we see the classic appearance of a hypertensive bleed right within the thalamus and the basal ganglia. Okay, so if I see this, actually if a radiologist just looked at this, they would call you back and say, what's the blood pressure, right? And now we're lowering the blood pressure, but we don't want to lower it too much, right? We want to kind of, there's a sweet point for kind of lowering these hypertensive bleeds. Here's another one that's pretty classic for hypertensive bleed. So if we saw this one, we would say, I think this might be a hypertensive bleed. Look at the history a little bit more closer. Here's, you can see a very bad bleed. This is a very large intraparenchymal hemorrhage or intracranial, intracerebral hemorrhage. Notice here that we have a lot of shift. Do you guys see the tension within the right side of the brain? Everything is being moved across. So what we have here is subfalcine herniation. We have herniation underneath the falx. And so the brain is actually moving from right to left, okay? Notice the effacement of the ventricle on the patient's right side, everything getting pushed over to the other side. And we can also see the development of some edema around the bright or hyperattenuated. We talk about attenuation in terms of CAT scan. It's all about the Hounsfield units, but bright is what you will see with acute blood. And we start to see some darkening around there, and that's actually cerebral edema that's building up. Here's another one where you have some more edema, again, subfalcine herniation. Here's the coronal from that patient, and here you can see just how much damage has been done. Notice that the falx is actually bulging across, so we have subfalcine herniation. Everything is getting pushed over from right to left, and also we start to see some tension moving down as well. So this is one we're going to want to call the neurosurgeon on right away, and they're going to probably have to do something about this to get rid of the high pressure. This is an interesting case. I told you before that the cerebellum is very hard to image and often missed in terms of with bleeds. This was a younger patient who presented to the emergency department with inability, just could not walk. And everyone thought that the patient was just kind of making this up, but the patient really could not walk. And then when we did the nystagmus, it was both horizontal and also vertical. And you know, when neurologists love it when they see that the vertical nystagmus, that is usually central. Okay, so central in cause. We got a CAT scan, and we can see that there is actually a bleed within the cerebellum. This turned out to be an AVM. Patient was quickly diagnosed, operated on, and actually did very, very well, so had a very good outcome. Okay, so one of the times where you can see pathology within the cerebellum, but sometimes it can be difficult. Intraventricular hemorrhage, this is not uncommon in older patients where they can bleed directly into the ventricle. This is bad. As we talked about, getting blood within the ventricles causes block and will be a cause of hydrocephalus. Okay, so these patients are always going to need to get a shunt. So when you see blood within the ventricle, like an intraventricular hemorrhage, please call your neurosurgeon. They will tend to put a shunt or a bolt in. Here you can just see blood that's extending into the ventricle from an intraparenchymal bleed. Okay, that actually goes into the ventricle. Bad. Now this one is rare. You're going to have to look pretty far and few in between. This is an epidural hematoma, okay, which is very different than a subdural hematoma. Subdural hematomas you're going to tend to see all the time in trauma centers. How many of you guys have seen an epidural hematoma? Like, come into your emergency department. Few guys back there? Anyone on this side? Few? Pretty rare though, right? When you're looking at them, you're like, what is that thing? Is that a big subdural, or what exactly is it? Well, the difference is that notice it has a very lens-like appearance. Do you guys see the way it's kind of bulging out? And this is really bad news because normally this is an arterial bleed, and it usually occurs due to a fracture of the skull with laceration of the middle meningeal artery. And so it's a high-pressure bleed, and this one is a ticking time bomb. I like to think of it as an MI of your brain. It's kind of like a stroke. If you're going to take one of the bleeds, this would be an MI of your brain, because the faster you get the patient to the operating room, you clip that artery, the patients can do very, very well, actually, if they get there quick. The problem is if there's a lag period and you're calling to try to refer this patient to a neurosurgeon and you're having a delay, there's only up to about 5 hours, and then not much can be done. So hopefully you guys will have some systems in place if you don't have a neurosurgeon right on your panel who can come in and take care of this patient, a system to get this patient out of Dodge quickly, right, to a place where they can do the operation that's necessary, because they can have a good outcome. This is an interesting one. This patient actually did not have a skull fracture, but got hit with a projectile with such force that actually this patient developed an epidural hematoma. And you can see it looks very different than when we come through and we'll look at some subdurals. This is much more lens-like appearing. Here's a small one. You might kind of quickly go through that and just kind of blow it off, but you can see that it's a very small little lens sitting over there on the left side, a more subtle appearance to it. On the coronal reformats, that's actually an epidural, not a subdural. It has more of a lenticular, although the radiologists were arguing back and forth a little bit if that was a subdural versus an epidural. The consensus was 5 radiologists said epidural and 3 said subdural, so we went with epidural. Subdural is much more common. We tend to see a lot of these in our practice, and we need to know that there's actually 3 different stages of subdurals. The acute subdural is going to occur within about 7 to 14 days. Tends to be bright or hyperattenuated, and we can see here it looks a little bit more like a crescent than a lens. Okay, so it's a crescent, like a sickle, and we can see there has a very high attenuation on the CAT scan. And notice here, though, even though it's small, there's some subphallacean shift. You guys see that? Everything's starting to move across. So it tells you that in addition to the bleed, that there's been some underlying brain injury and the start of swelling has occurred, and that's causing this midline shift. Here's another one, just a larger acute subdural. Notice again, this is acute, hyperattenuated. Again, we see that crescent. We see the herniation across the midline. And this is why I really like the coronals, because the coronals will allow you to see those subdurals that are layering along the vertex, along the very top, that you might miss on an axial cut. So I like to take a look through. I start at the top with my axial, but I do take a couple looks through the coronal, and I'll take one look at the sagittal. I don't have time to look at all the different images, super busy, but I just want to make sure that I've done my diligence by looking at the high yield views. Okay, so this one you can see would be important to catch. Again, here we see an early subdural, and we start to see that it's very small, but notice that it's constrained by the falx. Do you guys see how it kind of layers along the falx there? Because it's underneath the falx. And that's the difference between a subdural and an epidural. An epidural will actually cross along the midline and can cross the falx. It's on top of it, whereas a subdural is going to be under it and will be constrained by the falx. Bad, right? So you can see that on this one we have a lot of blood. We would say this is acute, this is hyperattenuated, and we see that there's a lot of shift here going from right to left, and we see mass effect with shift and herniation. Notice also that there's some blood that's layering along the falx. Do you guys see kind of in the middle there? So that's a periphalcine subdural hematoma, and we often will see blood layering along the falx. Here's a good example of just one of those periphalcine subdurals, where you can kind of see the blood layering along the falx. Okay. This is just a sequence that I wanted to go over with you guys, just starting at the top. On the very top of the vertex on the axial cuts, notice that we don't see a similarity between the two sides. Okay. The hemivertexes look different. So the left side looks more tight than the right side. I see gyri. I see some fluid on the right side, but on the left side it looks really tight, and it looks like there might be a bleed up there as well, right? You can see that little bright area. As we go further down, notice that, again, we start to see it looks kind of tight up in there, very different than on the other side. As we come further down, now we're starting to see the reason for this, and we can see a bright subdural hematoma. Notice that it's layering right there, like a crescent, and we can see it's bright, so it's an acute one. And notice that everything is being shifted across. So it's periphalcine herniation, and now we can see that everything is just a mess, right? Everything is pushed over. Lots and lots of pressure. Remember talking about those basilar cisterns before? Are the basilar cisterns even seen in this one? They're gone. Someone has stolen the cisterns. They're gone. Notice that they are completely effaced, and that's a sign that everything is being pushed down. So we noticed that there was periphalcine across the midline, as well as uncal herniation in this case. So the brain is actually being shifted downwards, so really bad case. And we can see again that everything is effaced, moving downwards. And just here's a good image showing the uncal herniation, and we can see that the brain is actually moving down onto the brainstem, which is never a good thing, And so this patient would need to get to the operating room relatively quickly. Just finishing up here, so as we go through some of the other stages of subdural, a subacute subdural hematoma that occurs between 7 to 21 days can be a little hard to see. Now this one you can actually see pretty well. I think it comes out look pretty bright. But take a look at that one. We could look at this and say, I think the brain kind of looks like it's on the wrong side of the head, right? Everything's kind of shifted over, but where is the subdural? And this is because a subacute subdural has the same attenuation as brain and can be tough. And so this is why sometimes giving contrast, getting an MR, can pick up those subacute subdurals that can be really, really hard to see. Here's just another example where you can see that the brain is shifted. It looks like there's something that's there, but this is actually a subacute subdural. And you can see just windowing in, you can actually, with different windows, you can bring out that subacute subdural. Let me come through to this. I thought this was kind of an interesting one where you have bilateral subacute subdurals that are perfectly in place to keep the brain right in the middle. Okay, so someone was very lucky on this one. So the brain is actually right in the middle there. And notice there's some areas of mixed attenuation where you have mixed bleeding going on. Later in time, as blood breaks down, it becomes dark or hypoattenuated. And this is a chronic subdural after 3 weeks. The chronic subdural will look dark, okay? And you can actually usually pick them up like this. Here's a chronic subdural, and you can see that basically just dark all the way down. Notice that, again, it can be a dynamic process, even with a patient coming in with a known chronic subdural, may have acute bleeding into that region, which is a big deal. They would normally have to go to the neuro ICU for a neurocheck. So you can see that there's some acute bleeding within this chronic subdural, okay? So here we see an image that has some midline shift. Looks like there's probably a chronic subdural here, but look how easy it is to read when you actually throw it up on the MRI. So if you have any questions about these chronic subdurals, just go ahead and do an MR, or you can do IV contrast would be your ways to go through. With that said, I'm a little bit behind on my lecture, but I think I have, just want to finish up with subarachnoid hemorrhage, which I think is actually really important. And then I have some examples of bleeds that I think came out really nicely. Susan reproduced each one of those plate by plate by plate. I think she wants to kill me. She's at the home office, but I think they came out pretty well in your textbook, so you can look at those afterwards. So let's just finish with the subarachnoid. With the subarachnoid, CT is going to be very, very good early, right? Where it's not so good later. And I think most of us would look at this image and say, that's bad. Our patient has basically a subarachnoid hemorrhage. And if we look at that, patient comes in with a thunderclap headache, worst headache of life, we would say basically subarachnoid hemorrhage. I don't think anyone would miss this one. This is actually called the Death Star, where you have blood that's layering out in the superior cerebellar cistern. And that's known as the Death Star, where you actually have the 5 points of the star that are all lit up by blood. But some can be subtle. And this is why, if you look there, you have a patient who's coming in, you're concerned about subarachnoid hemorrhage, worst headache of life, have the radiologist take a look, because they're going to window it in many different ways to look for subtle bleeds. I think this one's pretty subtle, and I could blast right through this image without seeing it. But actually, we got the call from radiology that this was positive, and we could defer the lumbar puncture. Remember that CT is very good early, and then lumbar puncture is better late. Here you can see is, again, this is a very small subarachnoid, could be subtle, difficult to see. This would be a good chance to call your radiologist to have them help out. And just to finish up, just so you know, if your patient does come in within 6 hours of the onset of the headache, worst headache of life, thunderclap headache, and you get your CAT scan, the sensitivity is so good, 98.7%, with a specificity of 99.0%, that I think a lot of people are now making the argument that do we need to do an LP if we're getting the patient within the first 6 hours. And I think that technology is moving very fast forward. I hope that we'll be able to get away from LPs, but if you can get the patients very quickly to the CAT scanner, this is going to be an excellent test, okay? And you can actually probably go ahead and defer your lumbar puncture.